And it's a question actually that was addressed in a randomized controlled trial that we were able to present at last year's ASH, and the clinical trial is now in press, and it addressed the question whether patients in first CR with intermediate risk should receive allotransplant in first CR, or whether transplant should be reserved until the first relapse. So patients were randomized, one half received chemo consolidation, no allo in first CR, and the second half received allo as a primary post-remission treatment. And the trial showed that the relapse risk is much higher in patients who receive chemo consolidation, but that these patients can be very nicely salvaged and brought to relapse transplantation, whereas in transplanted patients toxicity is higher, and therefore the survival curves, they cross in the beginning, but in the end the overall survival outcome of both patient groups was similar or almost identical, which means if you have a patient with intermediate risk, you should aim for allogeneic stem cell transplantation. However, if it's a borderline situation because the patient's hesitant, can't really make up his or her mind whether to proceed to allo or not, or whether you have a complicated donor situation or not a very well matched donor available, or there are concerns of toxicity, you may as well go for a post-remission treatment with chemotherapy first and only use allogeneic stem cell transplantation at relapse.